Good morning, fellows on the East Coast, West Coast, and around the world. We're very excited for our November 1st Fellow Project Lecture Series with Dr. Colleen Kennedy and Dr. Phil Schauer, and continuing with our powerhouse of surgeons from around the country. First, we have some announcements. Dr. Wilson, take it away.
Good morning, everyone. Hopefully you can hear me okay. Welcome again to the webinar. So just some reminders, ASMBS weekend is next weekend, November 7th through the 9th, with a pre-conference course focused on fellows, MIS Bariatric. So hopefully you guys have gotten to take advantage of that and gotten some time to join. It's a great opportunity to meet other people and especially to network with your colleagues and leaders in the field. So we're super excited to see you there, and there'll be some great speakers, great education, great learning. And don't forget, every month there's a bariatric fellow happy hour. It's the third Thursday or the fourth Thursday of each month, and so we would love to have you join. Remember to register for that on the ASMBS website, so you'll get constant reminders about that. And then always be on the lookout as an ASMBS member for other opportunities and announcements throughout the year and ways to serve, ways to get involved. And remember, you can always join committees. That's a great way to network and stay connected even after your training and fellowship is over. And I think that's all we have.
Thank you, Dr. Wilson. So today our focus is going to be on how we do gastric bypass and outcomes. And we will start that conversation this morning with Dr. Colleen Kennedy. Dr. Colleen Kennedy is on the executive board of directors for the American Society of Metabolic and Bariatric Surgeons. She's also our liaison and sponsor and confidant for the Bariatric Surgery Training Committee. So we're really excited to have her here. She's in practice in Dallas and has been one of the first 100 surgeons to complete the focused practice designation in metabolic and bariatric surgery. We're excited to have her as one of our experts in gastric bypass who's done it well for a long time. So we're really excited to have you here. Dr. Kennedy, take it away.
Thank you and good morning. One second while I share my screen. All right, good morning, fellows. As she said, I am a surgeon in Dallas, Texas. I'm actually in solo private practice, so I'm a bit of a unique situation, and I have been in private practice for a while. Been in practice for about 20-something years, and I've been in solo private practice for about 14. So this is a decision I made mid-career. And they asked me to come and talk about the gastric bypass and technique. In my personal opinion, has a lot to do with what you're good at and what you're used to. The way I currently do it is different than the way I did it when I began. I currently use a circular stapler gastrojejunostomy, and I am a laparoscopic surgeon. I have been a laparoscopic surgeon since the beginning, and I have been stubbornly staying a laparoscopic surgeon, and I will go through why that is my personal choice. We're going to look at the steps in the gastric bypass. The steps in the gastric bypass are the same. If you do it laparoscopic, you do it robotically, you do it open, though God willing, you don't have to do that. Why I use a circular stapler to do my gastrojejunostomy, and technical tips and pitfalls. So the steps are the same for everything. You access the abdomen, place your ports, create a pouch, measure your biliopancreatic limb, create an alimentary limb, create a gastrojejunostomy, measure your alimentary limb, create your jejunojejunostomy, close your mesenteric defects, test for a leak, and then close your fascial defects. Some people will do their JJ before their GJ. That is not how I was taught, and that is not the way that I do it. Your important considerations at all times when you're doing a gastric bypass or any other surgeries. Previous surgery, how thick's your abdominal wall? Always an issue. Positioning for surgery. I place my patients in the supine position with arms extended and footboard in place. Surgeon is on the patient's right, and the assist and scrub are on the left. So here's my ports. First port I put in is to the left of the midline and supraumbilically. It is approximately I got this in my way. It is approximately 18 centimeters. So that's my hand extended. It's been measured. And I do this using a direct visual access technique, which is a very slow and precise entry. So you enter into the abdomen carefully and safely. I then put in my right upper quadrant port, which is also a 12 millimeter, hand breath below the rib cage, mid-clavicular line aimed towards the GE junction. Next I put in is the mid-abdomen, which is this port right here, 6 centimeters left of the midline angled towards the GE junction. My left port, this one down on this side, is the assistant port. It is lateral superior to the umbilical port. And that's kind of a judgment call on where the rib cage are, size of the patient, shape of the abdomen. Then there is a right lower quadrant port, which is also a 12 millimeter. You'll see I use a lot of 12 millimeter ports just because I move my stapler around for the ease of the operation. This bottom one, the 12 millimeter, is used for small bowel manipulation and the jejunum and jejunostomy to make it easy. For liver retractor, it is a 5 millimeter port superior to the right upper quadrant. I do not use a fancy liver retractor. I use a prestige grasper that goes through and grasps the right cruce for my liver retractor. So my liver retractor is inserted in about 30 seconds. Next step is to create the pouch. What you have to look at is you got to make sure you ensure blood supply to the anastomosis, because ischemic anastomosis are difficult, and pouch size. You want your pouch to not be too big or too small. I use a 34 French gastric lavage tube or the endoscope to size the pouch. For revisions, I do use the endoscope. I divide the stomach between the second and third vessels on the lesser curve, which is approximately 5 to 6 centimeters down. I make what I call long and skinny pouch. It's one horizontal firing and then 2 vertical to go up. And then that way, there you go. Can't get us off the screen. That way you have a small and a port. Now I use it depends on your staple line. I have to use both the Ethicon and the Medtronic staplers. So the first firing is a blue, and then firing on the way up, the vertical, I use the green or purple lobe with a peri-strip reinforcement. I do continue to use staple line reinforcement. I've used it for 20 years. And my reason for staple line reinforcement, if you look at ultimate leak pouch, leak rate, et cetera, with reinforcement versus non-reinforcement and all the literature that we have seen, the leak rate's the same, the complication rate is the same. You look at the research on the reinforcement, the burst pressure is higher. So there's a theoretical benefit. The other benefit is actually it helps for your assistant. They have something to grab and hold on to, so they do not rip your stomach when they are retracting for you by holding the stomach. Next, we measure the biliopancreatic limb. In considerations, you have to see the BMI of the patient and the indication for your operation. First thing you do is you identify the ligament of Treitz, which you do by lifting the colon, finding the stop of the small bowel, and visualizing the IMV. Then you measure. You have to go at least 50 centimeters if you're doing this just for reflux, to decrease the risk of bile reflux and to allow for future assessment mobilization ease. I rarely use 50 centimeters for my biliopancreatic limb these days. That is mostly for my sleeve to bypass revisions for patients who have reached their BMI, but however have severe gastroesophageal reflux. For a higher BMI, I use at least 100 centimeters to increase weight loss with less malabsorption. And there has been studies to show that a longer biliopancreatic limb will cause improved weight loss over a longer alimentary limb without as much vitamin malabsorption. I divide the small bowel with a blue load if you're using the Ethicon, or purple load if you're using the Medtronic. And I mark the biliopancreatic limb with a clip to prevent a Roux-en-Y. After I mark what I believe is the biliopancreatic side with a clip, I trace back telegminotrites to confirm that that is indeed my biliopancreatic worm. If you do not want to do a Roux-en-Y, it is not a very common, but it is not an unheard of problem, and it is a difficult thing to deal with. I completed that. Next step is actually making the gastroduodenal anastomosis. What you need to look at is whether or not you have tension in your alimentary limb. Does your anastomosis lay comfortably in the abdomen? Is any tension or undue twisting will cause ischemia and an increased risk of an ulcer or perforation. And I do not use any permanent suture when doing the anastomosis. I used to use, when I started, 2 layers of pseudoethibond for I did a linear hand sewn, and the second layer, both layers were a semi-permanent suture. And I got to pick suture out of my anastomosis, and the foreign body sitting in the anastomosis was a nidus for a ulcer. The linear stapler hand sewn technique, which I did use for my first 6 years of practice, works very well. It's had excellent outcomes. I unfortunately have blown out 2 of my shoulders. And so I switched to a circular stapler in 2018 after my second rotator cuff surgery. So yes, both my left and my right shoulder have been operated on. And my first time I walked into a meeting with my arm in a sling, I cannot tell you how many of the, I will say older surgeons, but now I'm that age, came up to me and said, "Oh yeah, I had that done." So this is one of the issues with ergonomics and standing in surgery and the operation with laparoscopic surgery. The stapler and orbital choice, I choose a 25 millimeter EEA. It has the lowest rate of strictures, overall reported between 1 and 30, depending on what you look at in the literature. For circular stapler, orbital is a less traumatic way of putting the anvil in, and the 25 orbital has been shown to have the lowest rate at 1.7% of strictures. There's an article quoted here from 2016, and which demonstrated this 1.7% from Corky and al, showing the route of insertion with the orbital EEA. Now, the orbital is inserted by the anesthesiologist, so you have to have an anesthesiologist who knows what they're doing, because this can be a quite interesting experience when you have a new and inexperienced anesthesiologist placing it. So this is me. This is obviously sped up. And the circular stapler comes from the left side with the assistant port. My assistant actually places that stapler into the small bowel limb that has been prepared. And connection, that orange, when you're looking at this, the white means it is a 25. Blue, if you see a blue, then somebody gave you a 21 and you don't want to fire that stapler. There's my peri-strip that you see for holding. The stapler comes back out. You divide the blind end. Now you'll see I make a very short blind end of my candy cane. May not seem like it matters if it's a little longer, but when you come in to see these patients down the line when they're having issues with candy cane syndrome or sump, if you have left any substantial small bowel on the blind end, the patients will have regurgitation, reflux, and use it for a second stomach. So you can see that the blind end of my candy cane is very small. I do the anastomosis. You see it's laying comfortably. The mesentery has no tension. There is no issues, and there's no retraction up to the chest. That is a 2.0 vicryl. I'm old-fashioned. That is a 2.0 vicryl on an SH. Suture cut to 11 inches, which is about 23 centimeters, because I had to do 2 stitches with it. The same suture you use when you're doing an open operation. I have used the Karl Storz ergonomic needle driver for 23 years with a Riddick Olson, what I call my dolphin nose, in my other hand. Double throw, then a single throw. Officially, do you need these sutures in the corners? No. Is this a belt and suspenders? Yes. Am I too paranoid to not do it? Yes. And then there's your anastomosis. After you complete your anastomosis, I have anesthesia. Put a oral gastric tube into the pouch, and we do a leak test actually at that moment with instilling 60 cc's of methylene blue with occluding the alimentary limb. So now you're more than halfway through your operation. You turn to the measuring the alimentary limb to create the jejunojejunostomy. Once again, we're still looking at BMI of the patient, an indication for the operation. Measure from the gastro-J, know your distance. Use your suture to measure if you're not used to measuring how long you're doing the small bowel. Your alimentary limb needs to be at least 75 centimeter, which will prevent the bile reflux, because then you have a total of 125. If you go longer than 150, has been found not to be beneficial. So the longest I make it is 150, which is my higher BMIs. Make sure your common channel is greater than 250 centimeters. So say you have a high BMI male and you've now done 100, 125 on your biliopancreatic side, you got 150 on your alimentary size. Measure what your common channel is going to be. It has to be at least 250 or you will have short gut problems and a lot of diarrhea. And make sure you're tall, which is your total alimentary limb length or absorptive limb length from your gastro-J to your colon is at least 400 centimeters. Lengthening the biliopancreatic limb to have a tall of 400 centimeters improves your weight loss without significant diarrhea. There's also a technique to do when you're revising a sleeve to a bypass who has reflux and obesity. If you make sure that your limb lengths are good, despite all the reports out there, I have found that the patients do lose weight. When doing the jejunojejunostomy, most people think, oh, this is the easy part. I will tell you that not doing your JJ right will cause you a lot of trouble in the future. Your goals is a patent anastomosis without angulation, and you got a decreased post-op obstruction risk. A partial obstruction or obstruction at your JJ will blow out your GJ. And sadly, I do not say this from reading it in literature. I have seen it. I do what is called the triple staple or bidirectional technique. And why? I had a couple JJ strictures in the early career causing bowel obstruction and gastro-J leak from blood pressure. The rate of obstruction at the JJ is less than 1%. However, it is an impressive 1% when you see it. The bidirectional technique that I use is the lowest 30-day small bowel obstruction risk. And this is an article from 22 looking at it, technique in construction of the JJ and risk of obstruction, and the lowest risk has been seen using the bidirectional technique. That being said, you are looking at small fractions. As I said, this is a 1% or less risk. And we don't talk about it. This is something that surgeons talk all about the GJ, but no one talks about the JJ. Theoretical concern with the way I do it with a double staple is increase of bowel obstruction from intussusception. So in this, I now have the benefit of being above the lovely age of 50. I have experienced one operative intervention from bowel obstruction and interception in the last 20 years, and I've done over 2,500 bypasses in the last 20 years. It's probably over 4,000 bypasses. And that person was 8 years post-gastric bypass. That is the one I had to operative. Now, I had 3 operative interventions for small bowel obstruction prior to the technique change out of 750 bypasses. So I will take my intussusception risk. Rates are overall low. However, early small bowel obstruction is devastating. Now, final steps. You've got your JJ, you've got your GJ, everything's beautiful. Well, now you got to close your mesenteric defects. I use Ethibond. It is a semi-2-permanent suture. It gives it long enough for the defect to scar in. It is important to close your defect, so you will be back. It may take a couple of years, but you will be back. We have a surgeon in Dallas who never closed any defects. And whenever his patients show up in the ER with belly pain, we all know exactly what's going on. I got to close the left upper quadrant port site because the stapler went through it. We wash that thing in from the inside and the out. I use a zero vicryl. Yes, this is absorbable. That officially, quote unquote, breaks at around 4 weeks. When you examine these, when you happen to have to go back by a month out, the fascia is scarred. There is no signs of a hernia, which is a great thing. About 4 weeks, so about a month after surgery, the pain they have in the left upper quadrant is gone. I have less than a 1% hernia rate at that site with that technique. Once again, make sure you do a leak test. I do mine early, but OG inserted under direct visualization. Never let them put a tube down blind. And I use Nephilim blue and saline. For post-op pain, it is important to give them something of the local variety, not just in the skin, but in the muscles and in the nerves, innervating the abdominal wall. You have two options, on-cue pain pump or a tap block. I use the on-cue, mostly secondary to costs. On-cue is cheaper than Exparel in my facilities. Tap block also takes a lot more time with anesthesia doing it versus whether or not I do it. So I place an on-cue pain pump on every single one of my patients, and it stays in till 3 days post-op, and they take it out at home. Final considerations when you're doing a gastric bypass, because this is a beautiful operation. It is the gold standard.
Demonstrate.
It is the gold standard that everything is compared about. Number one, your assistant is key. I have had the same assistant for 8 years. I am very lucky in that. You need someone who knows what they're doing, particularly when you're in private practice. Number two, efficiency, no wasted movements. People say I'm a fast surgeon. I'm not a fast surgeon. I just don't sit around and waste time waiting for stuff. And do it the same way every time, if at all possible, primary or revisional surgery. When I do anything that is out of my ordinary, or I leave something, or I've taken a piece of small bowel or something, I announce to the room any deviations. They will write it on the wall. I know it sounds silly, but if you take a small piece of small bowel out and you never do that at the end of the case, you will leave it behind. So you make sure that that is written down. My average OR time, I know this because the robot people keep timing me, trying to tell me they can make me faster. My average OR time for skin to skin is 50 minutes, ranges between 35 and 75 minutes. I will say a lot of my fact that I can be so quick and efficient is because I have these people. These people are in my room every day, every week, every case I do at one of my hospitals. The gentleman standing there has been assisting in the OR for 30 years, and he's been assisting me for 8. So he's the other half of my brain, which is a very lucky step for me to have. He goes everywhere with me. The two ladies in the back, this is one of my 2 hospitals, and they are always in my room. So everyone knows what I want, what I need, when I need it. And we rarely have to talk about what's going on in the case. We do talk all the time. And that is all I've got.
Thank you so much, Dr. Kennedy, for that wonderful presentation. And I appreciate you also discussing kind of the pros and cons of each of your techniques and why you've made the decisions. I think that's really helpful for our fellows to hear. I look forward to their questions here shortly. Next up, we have Dr. Phil Schauer. Dr. Phil Schauer is a past president of the American Society of Metabolic and Bariatric Surgery from 2006 to 2007. And he's currently runs Pennington Labs as a chair of surgery, a professor of surgery there. He is probably one of the most prolific researchers in bariatric surgery in my generation. And I look forward to hearing about the outcomes of bariatric surgery from Dr. Schauer this morning. Thank you so much for joining us.
Good morning, Shaina. Can you hear me okay?
Yes, sir.
Okay. It's great to be part of this Fellows Conference, and Dr. Kennedy did an awesome job. I'm not sure I can add much to her fantastic presentation. Shaina, I just want to be cognizant of the time. I do have some slides that go over the outcomes, and I have a little video, but probably not enough time to do both.
Yeah, let's go through the outcomes focus there.
Okay, yeah.
Mhm.
Because Dr. Kennedy did an awesome job with the video. Okay, let me see if I can bring up my slides here. Okay, and can you see my slides?
Yep.
Okay, great. All right. Well, I think it's important for the fellows to sort of understand a little bit of history, where the gastric, bypass came from, at least in modern, at least the last 20 years or so, and where it sort of sits with other procedures. Back when I started in the mid 1990s, there was really only two really options. There was gastric banding and gastric bypass at that time. And then these other operations, particularly sleeve gastrectomy, has come into play, and then the duodenal switch. So around 2010, 2011 is when the sleeve gastrectomy really began to take off. And until then, the gastric bypass was the predominant procedure. So the sleeve has taken off quite a bit, and at the expense of the gastric bypass and to some extent the gastric banding, which is pretty much gone or become extinct. But I think there is, you can see a little bit of a upward slope of the gastric bypass in 20, 21, and 22. And I think this may be a trend to watch as we identify some of the imperfections of the sleeve gastrectomy. Now, listed here are what I think are some of the very strong attributes of the gastric bypass. For a large number of patients, it has excellent weight loss in the range of about 30% body weight or 65% to 70% excess body weight. And this has been demonstrated in numerous studies. It is very durable weight loss. There's data from the Swedish obesity subject study that now has outcomes out to 30 years, showing it's quite variable. I mean, it's quite durable. Excellent glycemic control. So it's a very good operation for patients with type 2 diabetes. There's quite a large amount of data showing a very strong cardiovascular benefit. And this may be perhaps the most important outcome of any bariatric procedure because, after all, our patients with severe obesity, what they die of is cardiovascular disease. Second place would be cancer, and the operation is pretty good for cancer too. And also, it has excellent control of acid reflux, which is a very, very common problem in our patients with obesity. So let's go through this in a little more detail. So this is data from the SOS study. This is from 2012. They've recently published their current data, which goes out to 30 years, which shows almost the same weight loss trajectory. And notice that gastric bypass, which is in green, at 1 to 2 years, you have this nadir of weight loss, which is around 32, 33%. And then there is an uptick with every intervention. There is an uptick from the nadir. But where the patients are at about 5 years is where they're going to be about 20 years, and for that matter, 30 years. So the procedure is quite durable, and you can see at 20 years, 27%, approaching 30% weight loss is really quite excellent and durable. And there's no other operation that has this type of data showing the durability of weight loss. And this is critically important when you consider that obesity is a chronic, often progressive, often relapsing disease. So the durability of the effect is really, really quite critical. And here's data from a very large study by Dr. David Arterburn involving almost 50,000 patients who had either banding, sleeve gastrectomy, or gastric bypass. This is more modern data compared to the SOS study. And you can see again the different weight loss, 29% for the bypass, 21% for sleeve, 8% for gastric banding. And this is a very large sample, and these are matched patients. So they're trying to deal with apples and apples here in terms of their overall comorbidity profiles. And then we even have 10-year data for gastric bypass. And here you can see in terms of excess weight loss, mostly in the range of the high 50s all the way up to 80% excess weight loss, at 10 years. Some of the differences are related to differences in initial body mass index, but also slight differences in techniques. In general, some of the procedures that involve placing a gastric ring around the gastric pouch proximal to the stoma, you see a little bit better long-term weight loss. But in general, this equates to about a 30% weight loss at 10 years, which is quite impressive. especially when you compare that to the 10-year data for sleeve. There's not near as many studies out to 10 years for sleeve, but with the sleeve, you see weight loss in the 22-23% range at 10 years. So there is a pretty significant difference there between these two procedures, the two most common operations for weight loss in terms of long-term weight loss. Now let's talk about glycemic control. This is a study that I was involved with, the Stampede trial, one of the first studies to compare the two most common operations with medical management for type 2 diabetes. This was a randomized controlled trial. These patients had fairly advanced type 2 diabetes. Over half of them were on insulin. Their mean A1C at the beginning of the study was 9%. They were on lots of medications, so it's pretty advanced diabetes. Most of them had diabetes for 8 years or more. And this shows you the changes in A1C, which is a very good marker of glycemic control over a 5-year period. And you can see with both the bypass and the sleeve gastrectomy, very nice drop in A1C that is mostly persistent out to 5 years. Whereas with intensive medical management, this was quite intensive, using insulin and a variety of medications to try to drop that A1C close to 6. You can see that it was not very successful. And by the fifth year, patients were back nearly to their baseline A1C. So both of these operations were pretty effective in patients with type 2 diabetes. Now, people often say, well, it looks like the sleeve is just as good as the gastric bypass. What this graph doesn't show is that patients who had the gastric bypass, the majority of them were weaned off all their diabetes medications, whereas the patients with the sleeve still required quite a large number of medications to maintain that glycemic control. So when you're looking at glycemic control, you have to look at not only the A1C, but what medications the patients are on to maintain that degree of control. And the other distinguishing feature here was that patients who had gastric bypass had a higher remission rate at 5 years than those who had sleeve gastrectomy. Now, this study was a sample size of 150, so it was not quite powered to show a statistical difference there, but other larger studies have clearly shown a greater remission rate for gastric bypass than sleeve gastrectomy in the long run. And this is the point I made earlier about the differences in medication usage. The advantage of surgery over medication is not only is it superior glycemic control, but it reduces medication dependency. So at 5 years, you can see that nearly half of the patients who had gastric bypass were completely off their diabetes medications, where about a quarter of the patients who had sleeve gastrectomy were off their diabetes medications, while the patients who were on medical treatment only were still quite dependent on medications, particularly insulin, which has significant negative implications in terms of not only body weight, but quality of life. We also saw major reductions in cardiovascular medications as well. Here's another large comparative study comparing remission and relapse, diabetes relapse between sleeve gastrectomy and gastric bypass. And here you see that, again, the Roux-en-Y was superior in terms of long-term remission and had a lower rate of diabetes relapse compared to sleeve gastrectomy. Now, there have been quite a number of other prospective randomized trials comparing surgery to medical therapy, and here's a list of 12 of them, and they all show surgery to be dominant over medical management, and most of these were studies of the Roux-en-Y gastric bypass. The only one that included sleeve was the Stampede trial, which I just showed you. But there's a very large, consistent and large amount of data showing that the gastric bypass is quite an effective operation for type 2 diabetes. And I want to share with you another 10-year follow-up study by Giltrude Mangroni and Francesca Rubino. And this study randomized patients to either medical management for diabetes or gastric bypass or biliopancreatic diversion. And you can see the big differences there between the medical management and the gastric bypass and BPD. And you can see that the gastric bypass was quite comparable to the BPD in this population of patients in terms of weight loss, around 30% total body weight loss. Now, whereas the BPD was more effective in glycemic control, the gastric bypass had quite good glycemic control out to 10 years, and that's shown on the right. But what's not shown here is that those patients who had the BPD had a much higher risk of nutritional complications, metabolic bone disease, and protein malnutrition. So there's a trade-off there. And probably in terms of the overall benefit of the patient, the gastric bypass for diabetes and the benefit in glycemic control and the lower complication rates offsets those higher complication rates with the BPD procedure overall. Now, probably most important is the cardiovascular benefit. And here I'm just showing you about 28 observational studies. And almost all of these studies are primarily dealing with the gastric bypass. There are a few banding studies in here and sleeve studies, but it's quite remarkable, and these were published in very high impact journals, that they all show a major mortality benefit for gastric bypass with an average risk reduction of about 45%, which is really quite remarkable. And I'm just going to share with you one of the studies that we conducted at the Cleveland Clinic a few years ago with Ali Aminian as the first author. This was a sample size of over 13,000 patients, and most of these patients had gastric bypass. And it's showing you that compared to a control group, the procedure was associated with reductions in mortality, heart failure incidence, stroke, heart attack, development of nephropathy, and atrial fibrillation. So pretty remarkable reductions in these major cardiovascular complications. And the number needed to treat, which is an important number when evaluating the effect of an operation, it only required treating 13 patients before you actually save one life. So that's pretty remarkable. When you compare this to some cardiovascular meds, some of them you have to treat 100 patients before you save one life. So the impact of these operations are quite impressive. And then finally, I'll say one other major attribute. I'll just pull one study here. Is the anti-reflux effect of the Roux-en-Y gastric bypass. And I would say it's by far of all the bariatric operations, it's quite clearly the very best operation for reflux. And frankly, I think this operation in many ways is even better than a Nissen fundoplication in terms of reflux. And here's one study that sort of shows that 53 patients who were evaluated for GERD preoperatively, and they were subjected to pH studies. And following gastric bypass, they had a significant reduction in their body mass index. Their GERD symptoms dropped significantly, as you can see, from 58% to 9% of the population. Esophagitis by endoscopy dropped significantly, and their pH scores, their Demeester scores, dropped quite significantly as well. So very strong objective evidence that this operation is very effective for GERD, and there are many others that corroborate this data. However, there are complications of this procedure, and there are limitations of the Roux-en-Y gastric bypass. I think it's quite an effective operation up to the mid 50s to a BMI of 60. When you get beyond 60, that may be a time to consider an operation with a longer bypass or more reduced absorption. You get about maybe a 20-point BMI drop typically with the gastric bypass. So in these higher BMI patients, many of them are still going to have severe obesity after the procedure. I'm not going to have time to go into all of these in quite detail, but marginal ulcers can be a problem in probably 3 to 5% of patients, usually associated with precipitating factors such as smoking or use of NSAIDs. Internal hernias is a big problem, and I think Dr. Kennedy touched upon that. Closed nose mesenteric defects is absolutely critical. Bowel obstructions can occur after these procedures from adhesions, internal hernias. Intussusception is not discussed as much, but this is a rare complication, probably less than 1%, maybe 0.5%. Most commonly, the common channel can intussuscept into that jejunostomy. I think a precipitating factor may be uh, uh, in the gastric bypass that's made with a very wide JJ anastomosis. At least empirically, that's where I've seen it most often when surgeons are creating a very wide anastomosis. So that may be something to pay attention to when you're making the anastomosis. Iron deficiency can be an issue related to reduced absorption of iron. Iron is absorbed in the proximal gut, which is bypassed. B12 deficiency because of a deficiency of intrinsic factor, which binds to B12, which is important for absorption, and that's reduced because of the small stomach pouch. And then metabolic bone disease is another issue that should be managed carefully. Patients should be on supplemental calcium and vitamin D. But this is an issue that we see, and if you follow patients long enough, you begin to see fracture rates that are 3 to 5%. But I think these can largely be avoided if patients remain compliant with their calcium and vitamin D. And I just want to with this slide kind of review some of the problems you can see at the gastrojejunostomy, stenosis, marginal ulcers. Of course, leaks can occur acutely at this site. Gallstones can occur with these patients with rapid weight loss. I do recommend prophylaxis with ursodeoxycholic acid or Actigol. Bacterial overgrowth, malabsorption, I think are pretty uncommon. We talked about bowel obstruction already, internal hernia, and the rare patient who may have bile-induced diarrhea, but I think that's pretty rare. I just wanted to mention again the internal hernia problem. You have the defect at the Peterson space, which is the blue arrow. That needs to be closed, and this is the retrocolic, retrogastric construction. And then you have the defect at the jejunostomy that has to be closed as well. And this can result in not only a bowel obstruction, but a closed loop obstruction, which can lead to fatality, or what may even be worse, loss of a large portion of the bowel, and the patient, may require TPN for the rest of their life or a bowel transplant. So a complete disaster if that does happen. So finally, let me just conclude. I do think the Roux-en-Y gastric bypass is an excellent operation. I think it's underutilized today when we're finding out that many patients who have a sleeve gastrectomy are coming back within 5 years for revision or for severe reflux. The gastric bypass has excellent magnitude of weight loss, durability, glycemic control, excellent proven cardiovascular benefits, an excellent operation for reflux, but it's not without complications. So you really have to master this operation so that you can minimize these important complications, which Dr. Kennedy has also so nicely illustrated. So I think I'll just stop there, and perhaps we can open up for a discussion.
Excellent. Thank you so much, both of you, Dr. Schauer and Dr. Kennedy, for sharing your insights and your expertise. I think it's really important for us to just to learn and see different perspectives. For the fellows, I know you're seeing multiple various techniques in your training. So I'd just like to kind of start it off. Going back to Dr. Kennedy, You mentioned kind of your injuries and how you still elect to do laparoscopic surgery. And I personally don't think it's going away, but I do both lap and robotics. If robotic surgery was introduced to you earlier in your career, in the first 5 years, knowing what you know now with your injuries that you've had, do you think you would have adopted it?
And that's an excellent question. As I said, the technique that works best for you is the one that you are the most proficient at. And it is difficult at this point of operating laparoscopically for 20 something years to switch to robot. I did try the robot. Unfortunately, my shoulders are not my only problem. So the robot actually made some of my other issues worse.
Mm,
Um, so if I had started on the robot, perhaps I would have embraced it more. I do recognize fully that my one limitation uh, that I have now is my assistant, that I am grateful that I have had a series of excellent assistants that work with me every day.
mm,
The robot in my world, when you're in private practice, your assistant is key, and the robot takes that variable out of it. So I might have embraced it more. Um, I think anyone who uses the robot you can get excellent results. We have shown it. The robot and laparoscopic results are comparable. I might have embraced it more. Um, I don't think either technique is bad. It's just in my hands, I do a better job with the scope. I am looking forward to the heads up robots, and I have had the pleasure of seeing some of the ones that are coming out there and sitting on them. And so maybe perhaps,
mm.
and some of my initial resistance to the robot with the stapler, et cetera, they are making improvements. I've had people chasing me for 20 years trying to get me to use a robot, and I'm always like, eh. So I'm still trying it, and I'm actually after the first of the year visiting my good friend in South Carolina to see how the DB5 might be better. Though I will say the intuitive people are mad that I pushed it off to the first of the year, but this time of year is just too crazy.
Yeah. Yeah. End of year is always crazy for sure. And just one more question on that note. Do you have a BMI cutoff that you'll do because you're laparoscopic?
No, I do not. I do not have a BMI cutoff at all. Particularly, and as you're all familiar, it depends on where the body is. Are they belly or are they all butt? One of my hospitals is smaller. We have a size cutoff there, but I take the larger patients to my larger hospital because it is always safe for the patients. Generally, I mean, the none of us get a lot of patients over a BMI of 90, but I do a lot of patients 80 and below, and that is the majority of our patient population that gets healthy enough for surgery anyway. Um, I was first introduced to the stage technique for bypass actually by Dr. Schauer when I was visiting him when I was starting looking at fellowships.
Mhm.
Um, and so I think on the higher ones, I would probably still consider a stage procedure for safety of the patient because particularly for the bypass, you can't move the mesentery at a BMI of 90 very well. But no, I don't really have a limitation at all.
Okay. Excellent. Great to know. Uh, and segueing to you, Dr. Schauer, with the rising popularity of the SADI and duodenal switch coming back, more people doing that. I'm not sure if that's going to eliminate the gastric bypass from going away, just because those are difficult. The duodenal dissection is difficult. I'm not sure everyone is going to just so easily adopt that. But a lot of folks want to see the gastric bypass improve. They're worried about ulcer rates and maybe long-term weight loss. Is there a way you can see us making the gastric bypass a better procedure or more effective and maybe comparable to maybe the SADI DS?
Yeah, I mean, there has been forays into that. Yeah, we can't make the gastric pouch that much smaller, and there might be a slight benefit with a smaller pouch with respect to not only weight loss but also marginal ulcer rates. There does seem to be a correlation with large pouches and ulcers. I think ulcers can dramatically be reduced just by good counseling. It's primarily NSAIDs and smoking that are the problem there.
Mhm.
So there are surgeons, and there's actually level one evidence suggesting that a banded pouch does better than a non-banded pouch. And it's not been popular in the US, but there are groups in Europe, and there's a nifty little adjustable ring that can be placed or proximal to the anastomosis. And it's not placed tightly, it's placed fairly loosely that seems to add maybe another 4 or 5 BMI points to the gastric bypass. That device is not FDA approved, that's why it's not used in the US. You can make your own little ring with the silicone tubing pretty cheaply. Um, and then the third thing you can do with a standard Roux-en-Y gastric bypass is lengthen the BP limb, and that's being evaluated. I'm not sure the jury's out on that as to what is the exact best length of the BP limb, but there are some studies showing longer BP limbs, 150, 200 or so, can perhaps add a better glycemic control and possibly weight loss, but the jury is not out on that just yet. Yeah.
Mhm.
But yeah, I mean the SADI has definitely increased popularity. It's an operation I do. I usually do it in a staged approach for high BMI patients, do a sleeve first and then the SADI. But I can't underestimate how important it is to follow these patients and their long-term nutritional sequelae, something that we surgeons don't often pay as close attention to as we should. And some of the folks can get into big trouble late, 5, 10, 15 years later, because they're not adequately monitored.
Yeah.
Got a couple questions in the Q&A. Evan asks that you mentioned for either of you that the total alimentary limb should be around 400 centimeters. Are you measuring your total alimentary limb length on all your patients? How can you ensure that that's consistent?
Well, I can tell you, on my patients, no, I don't measure on all. I probably should. On the patients where they are a higher BMI, and my higher BMI is above 50 is when I make my biliopancreatic limb longer. I will absolutely measure to where I think the BP limb should be, and then I measure the total length I have back. I do not want to cause a patient to have a short gut kind of picture or a common channel less than 250. 250 is a pretty safe number. When you look at short gut studies, they say you need at least 150. I have definitely, and I'm sure Dr. Schauer has definitely had people where we have a shorter common channel and we deal with diarrhea all the time and fat malabsorption and all the problems you see with the DS. So I will measure my larger people. And the BMI over 50 is where I very much work on having a tall of 400. My smaller people, generally, if the lower BMIs not always have a less of a metabolic, a less severe disease. They have a less severe disease of obesity and they have less issues most commonly, but not always, because I have some pretty healthy BMI of 70s out there. And so I don't go for as long of a bypass because they don't need it to treat their disease.
Gotcha.
Yeah, I would agree with Dr. Kennedy. I don't measure the entire limb length or the entire bowel in all patients, but in the higher BMI, when I'm considering modifying the BP limb length, I do. And it's not that difficult to run the bowel. It's a good technical exercise for fellows. It probably adds realistically 5 to 10 minutes to the procedure. And you have to be careful you don't, injure the bowel as you're running the bowel. But that's when I do it. I measure it. I think whenever you're going to modify that BP limb beyond, typical 50 centimeter length, I would measure the entire small bowel length.
Yeah.
It's interesting because there have been a few studies on kind of proof of concept. Is it worth it? And the risk in a small series of patients is pretty low, to your point, Dr. Schauer, and it takes for them, it took them, I think, 10 to 12 minutes to add to the procedure, done in about 100 patients. And then one of the colleagues here in North Carolina, Peter Nong and his group at UNC Rex, they measured the bowel to decide on percentage bypass for their SADI. and have started adopting that for their bypass based on some data, kind of thinking of trying to put all the interesting data together of the weight recurrence risk we have, the malnutrition we have, weight recurrence with bypass, malnutrition we have with duodenal switch, and the fact that we've learned a lot since really distalizing gastric bypasses to too short of a common channel, and maybe using some of this data that we're learning from Tall and Dr. Nameri and Dr. Diassi to help us with it. I feel like that's where I feel like it will be interesting in the coming years to see where we land out. I feel like where we've been traditionally with our bypass limb lengths, and I haven't changed, I will fully admit, even though I'm saying this, I think that's probably where I'm most likely to change. And it's the easiest to change to improve tension times is lengthen your BP limb to overcome tension, getting your Roux limb up to your pouch.
Yeah.
Excellent. Kristen asks, do you have any thoughts regarding the single anastomosis gastric bypass, pros and cons for either of you?
Yeah. I guess the potential advantage is you're maybe reducing time. You're not doing a second anastomosis. But there are some disadvantages, and the recent 5-year randomized trial study that was published showed that there wasn't much difference in weight loss, but there was a higher rate of gastritis and reflux in the loop bypass. So that's something I'm concerned about. And so I don't see a big advantage with that procedure. Maybe a little bit quicker, but in terms of weight loss, probably no difference. But in terms of problems with gastritis, reflux, and so forth, there does appear to be a problem there.
Excellent. And Nathan,
I would
go
agree
ahead.
with Dr. Schauer on that one. I've had this argument with Dr. Billy on a regular basis, and I think a lot of it goes with technique, as we said before. In Dr. Billy's hands, the one anastomosis gastric bypass does an excellent thing, but he's been doing it for years. What I see coming into my ER is issues with bile reflux and ulcers and perforations, the same as you see in everything else. The theoretical benefit is you don't have a JJ, which will decrease one spot for an internal hernia and decrease your operative time by, 15 minutes. So you got that.
That's great.
Yeah, that 15 minutes, when you think about the lifespan of a patient, doesn't seem so important. Yeah.
For sure. And Nathan asked, can we look forward to studies comparing these new weight loss medications, GLP-1s, to the bypass or the sleeve or our standard operations?
Yeah, that's what we need to do, and what we really need, since there is evidence now that semaglutide from the SELECT trial in a very large study does actually reduce cardiovascular events, major cardiovascular events by 20%. What we have with the surgical data are large retrospective observational studies. We don't have, unfortunately, the gold standard prospective randomized controlled trial data. What we do need is a head-to-head comparison of these. I'm very confident that the surgical procedures will do extremely well compared to GLP-1. But such a trial would be I've been trying to get started for many years, very expensive, and it requires that the companies that make the GLP-1s provide the drugs, and they haven't been willing to do that so far. They don't want to subject their product to a surgical procedure.
Excellent.
I can see why. Yeah.
Right.
Yep. The other one I'd be interested in seeing, because I treat it like the drugs are like the chemo for our cancer that we're treating, is the outcomes. I personally think we all know that we get our patients down and they lose about 60 to 70% of their excess body weight, but they still have excess weight that they're dealing with. And then when you add meds, which I do postoperatively in my program, we get the patients all the way across the finish line. So I would like us to demonstrate that we can show that you get them 70% of the way with surgery, 100% of the way with surgery plus medication. Medication alone, you get about 30% of the way. Like, I think that there really should be a combined multidisciplinary approach to the disease of obesity in this way. And I would love for someone who is liking research so much more than I do to actually be able to have that kind of study. And I'd love to see the results.
Yeah, that's a good point. It's not just either or, it's the
Yeah.
combination, which is the future for sure.
Yeah.
And using the drugs up front. Dr. Ken and I just talked about these very high BMI patients, and one clear way to get them optimized, suitable for surgery, is to get them some weight loss. There's nothing more therapeutic than weight loss. So, in our own experience, we've had patients lose 100 pounds or more with some of these GLP-1s in preparation for their bariatric procedures. That can be very helpful. And then, as
Yeah.
Dr. Kennedy said, on the back end, some of the folks who don't quite reach their goals, weight loss goals, add in the drug. Why not? They do work post bariatric surgery. Yeah.
Yeah.
The
There have
big
been
problem, though,
more and
is,
more.
I'm
Oh,
sorry.
go ahead.
I was going to say the big problem is they're so expensive. The drugs are very expensive. We have to keep that in mind and put that in perspective with surgery. And this may be one of the most underrated aspects of bariatric surgery is that our operations are extremely low cost, extremely low cost. A year of treatment with semaglutide is $10,000. Okay, that's about the price of a sleeve, or almost the price of a sleeve. That's just 1 year of treatment. Um, and our operations last, technically they last a lifetime, you know, so they're very, very cheap.
I feel like there are more and more studies coming out about the cost and that cost comparison. And it seems, at least in some of these smaller series in the review studies, 2 years is that cost, where it becomes probably close to a break-even point. But I really do, uh, you know, and probably preach too much about it, but the rising tide lifts all boats. If we're able, I think if we focus on the patient kind of like a cancer patient, and I hate to, you know, bring that up that way, but at the same time, it's really true. We should offer all of what we have for every patient who has the disease of obesity in the way we do for our patients with cancer, and treat them for the rest of their lives like we do with our patients with diabetes. And we'll be much more effective long term. We're most of the patients getting treatment for obesity around the country right now are done by people who don't necessarily understand as much about obesity as us, our primary care providers. And so the more we work with them, I think the better for all of our patients, and we'll be able to increase access to bariatric surgery as well.
Absolutely. Well, I think that's all the time we have. We will have an afternoon session again, hopefully with our speakers coming on after their talks play to answer more questions. But thank you, Dr. Schauer, Dr. Kennedy, for sharing your expertise once again. And thank you, everyone, for tuning in and participating. Have a
Have a
great
good day,
day.
guys.
Very much. Take care. Have a great day.
Thanks for joining us live, Dr. Kennedy. Marc and I are moderators for the afternoon session of these Fellows Project, and I will just let the folks ask their questions.
Janine.
All right. Thank you for the talk. Do you consider switching any of the 12 millimeter ports to 5s, and do you close the 12s?
A good question. I actually do not. I only close the 12s where I have stretched it in any way or taken anything out of it. I do not close them. We actually did a paper back in about 2004, 2005 of the Rosenthal group, where we looked at about 7,000 12 millimeter ports that had not been closed, and the hernia rate was less than 1%. This is about when we changed from the blunt tip ports to the direct visual access dilating ports. So it splits the muscles instead of cutting them. So when the muscles come back, the hernia rate is low on those. In those 12s, you don't actually have to close. I move my stapler all over the place, so I keep 12 so the stapler goes through.
The next question here, Dr. Kennedy, can you speak more about your JJ technique? It sounds like it has changed over time. Can you describe how you make your JJ currently? And thanks for the great talk.
Okay, so I was taught how to do my JJ back in early 2000s. And at the time we had shorter staple loads, and we would do 2 loads of a blue load GIA going straight down, and then you would close laterally. What that leads to, unfortunately, as some people have dealt with it, is you can very much have a narrowing as the alimentary limb comes into the jejunojejunostomy and leads to the bowel obstruction issues I had then. I had a few bowel obstruction problems, and so I looked at it. I first tried with what's called the Brolin switch, described by Dr. Brolin, to try to keep the JJ from kinking, because that's what would happen, causing bowel obstruction. And then I had another problem with somebody who had that. So what I do is called the tri-stapler technique. So I use a 60, go straight from my side, straight down between the two limbs of the JJ. And then I have my assistant come in from his side, and he fires in the opposite direction. Now, he does not take the full 60 stapler fire, but it makes a wider anastomosis and decreases the kinking. So basically, my Brolin stitch was replaced by a staple fire in that direction to hold the JJ from twisting. And then we use the stapler to close the defect in the small bowel. I actually have not had a bowel obstruction at the JJ from a twisting or kinking since I switched my technique. And I switched my technique back in about 2006, I want to say. So it was a while ago.
That's great. You know, it's interesting. A lot of people, I think, use that technique, but it's not very commonly described. I use that technique. I was trained to use that technique. And I suspect that might also be why you don't see as much intussusception, because I think intussusception is occurring. It's always when they get stuck in the JJ, though. And if your JJ is wide open, I don't think they have clinical symptoms.
Right. And I don't know, I've had scans where they have intussusception on CT, but it's not obstruction, and contrast goes downstream. And I tell them not to worry about it. So I agree with you. I only had to take one to the OR for actually obstruction there. And it was a weird one where the biliopancreatic limb got stuck in the JJ somehow. So.
Okay. There is the moderator is telling us there's one question in the Q&A. Oh, what are some deficiencies that are most important to take care of with the gastric bypass?
So all of them, but I will tell you the most common ones that I see. I see a lot of vitamin D and vitamin and iron. Those are the big two. You have to be very aggressive on checking and monitoring for thiamine deficiency. And if you have someone who's vomiting post-op and you can't figure out why, it's very commonly thiamine. And in the whole medical legal area we have now, thiamine deficiency is well known. And if you miss it, you will be sued. That is not why we replace it. We replace it because they have neurodeficits, but it's one of those big ones. Interestingly, lately, I find patients have more and more vitamin A deficiency. It might be because we have lengthened the biliopancreatic limb, so there is more malabsorption. So I have added vitamin A to my routine vitamin checks. But the ones I chase all day long is iron, vitamin D, free op, vitamin D deficiency, everyone. Discussing it, Americans don't get enough vitamin D in their diet. We're not out. I'm in Texas and we don't get enough sunlight for it. And all of our food is so processed that the vitamin D is no longer in it. So we all need supplements.
Yeah, and I think that you know, I think you're involved with the task force that's working on the thiamine deficiency, or maybe you're involved with communicating that to the EC. But thiamine deficiency for the fellows can occur within 2 weeks after bariatric surgery and should just be treated empirically. You don't need to confirm. It's virtually risk-free to treat with thiamine, and you could prevent potentially catastrophic neurologic damage.
Yes, for those of you, when you go into practice, every ER should have a protocol that when a bariatric patient comes in, they get thiamine hung no matter what their complaints are while you're doing the workup, because it helps protect them and you. And there are devastating complications from thiamine deficiency.
Absolutely.
I have a question for you, Dr. Kennedy, while we're waiting for some more people to type in. I thought you made a really interesting comment about choosing your team and having the same people over and over. So often in my career, I have been sabotaged by the new person who comes in, the unfamiliar person that comes in. What advice could you give the fellows about building their team?
So I'm lucky, as people say. So I have gotten to the point in my career, thank God, that like I do my surgeries on Mondays and Tuesdays. I have an established team. I am lucky that I get to run my programs in every hospital I'm at, which is kind of nice. I'm very spoiled. I am very much a princess. But when you pick your team, honestly, you have to know, and I know this sounds crazy, but you need to know how to do your own stapling, how to load your staplers, how to put on your strips if you know how to do it, how to assemble the harmonic if you're using the harmonic. You need to know how to do all that because when you pick your team, you will be training your scrub nurses. If you have a scrub that is good, enthusiastic, could be young, could be old, wants to learn, and let's face it, you're nice to them because sometimes we get cranky, myself very much included, then they'll want to come back. And if you talk to the OR staff, I have made it a point in my hospitals to say with bariatric patients, you get one chance, you do it right, or you're going to be dealing with them for months. And so if we have the same team every time, we do it right the first time. And over time, if you continue to show that, the OR will let you pick and people want to be in your room. It doesn't matter if it's the newest nurse or the seasoned nurse. You need someone who is dedicated to what you're doing. And I'm spoiled, so I get who I want, which is a very lucky for me. And sorry
There's
for
a
the fellas, it
question.
takes a little while for that.
There is a question in the chat. Why do you use Ethipon versus silk for the mesenteric closure? And do you run it or do you interrupt it?
Okay, so the second part is easy. I run it. I start at the bottom and run up to the bow, and I do my final stitch actually from bow to bow, which further anchors the JJ from not twisting. I use Ethibond over the silk. It is mostly permanent suture that'll cause the inflammatory and the reaction that you want to scar the mesentery in place without being there for 60 years. However, I've gone back 5 and 10 years after my surgeries, and you can still see a little blue where the Ethibond was, but there's no defect, which is nice. And in all honesty, I started using it when I was a fellow under Raul Rosenthal, and so some things never change.
Yeah. I try to avoid silk at all costs in the abdomen. I've seen once or twice bowel obstructions from massive inflammatory cascade. And I completely abandoned silk in the belly. There's no question. So I have a question for you. What do you think about the evolution of limb lengths? So as a surgeon in practice, I kind of vary. I was classically trained 40-100 for bypass. I'm doing probably like 60 to 80, 120 now, depending on BMI and patient characteristics. I hear about people doing 100 BP limbs. Really, the entire bypass anatomy is probably not supposed to be more than 200 centimeters. What do you think about that?
So my thinking on this has evolved over time, and it very much depends on patients and population. My limb lengths when I was trained, it was a BP was 50, which always ended up shorter when you went back. And the alimentary was between 75 and 150, depending on BMI. I started learning the gastric bypass from Harvey Sugarman in an open technique. So that tells you how far back it goes. We also with Harvey, so this skewed me, we were doing studies on BPDs in the open and comparing them to long limb gastric bypasses. So back when I was a resident, we were looking at long limb gastric bypasses and malabsorption in comparison to BPDs. And I had always found it interesting. You had to handle the difference in weight loss versus malabsorption, basically, because long limb gastric bypasses, which most people don't see anymore, they were profoundly malnourished, and the diarrhea rivaled that of the JI bypass and the BPD and the duodenal switches when it started, when they had 100 centimeter common channels. And so we went completely the opposite with all the malabsorption, particularly if anyone who's ever taken care of an old malnourished JI bypass, you don't want to see that ever again. And we went short, and then we saw the weight loss fall. So I have found it interesting when you're looking at, I think it's getting well established that 200 or plus of a common channel, 200, 250, will give you enough absorption that you're not going to have the profound diarrhea. I find it fascinating that limb lengths on the alimentary side, when you went from 75 to 150 to 200, some people were doing 250, that didn't make a difference in weight loss. But when you change the biliopancreatic side, it does. And so I went back to 100 centimeters for my elementary side, and I buried my BP limb, depending on the patient. And I routinely go 75 at least to 100 or 150. But then I do count my downstream common channel to make sure I'm not causing a malabsorptive, because I stick very strongly to the belief that your total elementary limb has to at least be 400 centimeters. So, because I don't want to deal with the malabsorption. And it seems to be working. Interestingly, we used to have a lot of constipation with the old school gastric bypasses, and with lengthening of the BP limb, I just still deal with constipation, not badly, which is a nice thing. It's fun watching the field evolve. We learn every day.
We don't have any questions in the chat, so I'm going to take advantage of this to ask you a question as well. My technique is almost mirror image to what you do. We must have been trained by similar people. I've struggled with the infection rate at that site you bring the EEA through. And I have the robotic reps standing behind my back as well, telling me that infection rate will go away if you use the robot. What can you tell the fellows about bringing in EEA through the abdominal wall?
So the left upper quadrant port site is definitely the bane of my existence. When you are taking the circular stapler through the abdominal wall, the nature of the business is we are bringing in a clean stapler. That's not the problem. Big problem is the amount of tissue damage as you're bringing it in. And we used to, about 5-10 years ago, have this great little cap that went over it that they stopped producing. And when they got rid of the rounded cap to go through the belly wall, the tissue trauma went up. And so then bringing it in, there's a couple things that we've done to try to decrease the tissue trauma. I have occasionally swapped out the 12 port where I'm putting the circular into a 15, so we have a larger dilated area because we're closing that port site anyway. And then we try to minimize the stretch and the bring through. This goes back to somebody knowing what they're doing for the manipulating through the abdominal wall, because the less tissue trauma you have, the better. And then when we come out, I irrigate it from both sides. From the inside with saline from the irrigator, but from the outside, we actually use a little dilute betadine when we irrigate out the port site. And then we wash all that out with saline before we close it, and then close and then wash again. I won't say I don't have wound infections, but I will say it's going down. That is the biggest negative to the circular stapler. The robotic guys say that goes away because you have to hand sew your anastomosis with the robot. And the hand sew is a great technique. Any technique for doing your anastomosis is good if it's one you're comfortable at and you've done a lot. My last hand sewing of anastomosis was open, and I did not enjoy the open hand sewn gastric jam.
How do you deal with the rare hypoglycemic hyperinsulinemic response after a gastric bypass?
No, the delayed or the immediate post-op ones? The ones that are years out? Yeah. So I do really consider that a form of dumping. And you see it very commonly in the people who used to be diabetics. Interestingly, there's a couple different things. I slaughter medication names, so I'm just going to put full disclaimer on that one. I have used the ASRBOS or ASRBOS and schedule them that, and they do better. I make sure that they are eating like every 2 to 3 hours, something with complex carbs plus protein. And if they were previously a diabetic, interestingly, putting them on a low dose GLP-1 will slow down the emptying to the point that their sugars stabilize. For the ones that are really resistant or dangerously low, I have reversed them back, reversed their bypass, and I kind of reverse their bypass to a sleeve so they don't gain all their weight back because they're all scared about that. But you got to be careful when you do that to make sure it is a good reversal plus sleeve, because otherwise they will have a kind of a empty area on their excluded stomach where food gets stuck up high by the fundus, and then they're miserable from reflux and pain. What have y'all been doing?
Same. We've tried Kissing X, earlier mixing of the alimentary and the BP limb to try to ameliorate some of that. mixed results. And we've had patients that have gone on to require pancreatectomies, even after reversal.
Oh, wow. Haven't had that in a while.
Yeah, it's pretty devastating when that happens, because the degree of pancreatectomy seems to be variable depending on the surgeon, the hepatobiliary surgeon that does it, and the response, you know, if you don't take enough, it persists, and if you take too much, they end up with pancreatic insufficiency. So it's a pretty bad problem.
The other interesting thing I've been using for them when their sugars drop, I have them eat a dairy product, like have 4 ounces of whole milk or have some regular yogurt, because then the fat plus the sugars in the milk products will stabilize them better than if they have sugar, which they think is the answer, which will immediately have them bottom out even more. And so adding in something that has fat plus protein and no simple sugars really seems to help them when they drop out.
Apparently there's a new drug designed for this. I think it's in phase 2 or 3 trials right now. I don't remember the name. It starts with an A, but it's I heard about it somewhere, probably out of desperation, looking for answers.
Yeah.
Well, Marc, do you have any other questions for Dr. Kennedy? Oh, you're muted, Marc.
A ton, but I think we're at time. So I think we thank you very much, Dr. Kennedy, for your time and a delightful lecture this morning and this afternoon.
Absolutely. Great lecture. And thanks
Thanks
for
for
joining
having
us for the afternoon session.